Good afternoon, and welcome to the webinar this afternoon sponsored by the Healthcare for the Homeless Council. Medication-assisted treatment, changes in federal policy will help increase access to opioid treatment in the HCH community. I'm Barbara DiPietro. I'm the Senior Policy Director for the Council. I'll be the moderator today. Really excited to have this conversation. This is part 2 of a webinar series that we've done focused on MATs and serving homeless populations, and so we wanted to continue the conversation that we had in August. We had a tremendous showing for that. We've got over 200 folks that had registered for today's conversation, and so I think this really speaks to obviously the HCH's community's interest in opioid addiction, but specifically how do we make MAT treatments work in our environment. And so we really just wanted to look at some of the federal policy changes that have happened, talk with SAMHSA about what those mean, and then really get a chance to dive a little deeper into some of the operational aspects of making these policy changes work in our projects. So just want to take a few minutes to talk about why we're even really having this discussion, if that even needs to be outlined. But as we know, there's a myriad of policy changes that are going along with a growing recognition of the opioid issue. We're seeing a lot of changes in funding for access to treatment and prevention. We're seeing a lot of states who are doing more with changing how Narcan or naloxone is available to the public. We're seeing more harm reduction approaches being implemented, which is really good to see, particularly focus on needle exchange. And then we're looking at how can this really be folded into a diversion or alternative to incarceration. So this is a direction that we've been pushing for a while, and obviously this is really starting to push harder on that. We're glad to see this policy change. We know this is just one approach, medication-assisted treatment, to recovery in a primary care setting, but it's one that we think works really well. Evidence is obviously an evidence-based practice. We're seeing that the increasing prescriber rights, so this is really a big thrust of today's conversation, is how do we incorporate a broader range of providers into prescribing Suboxone and other MATs, and thinking about how these providers are increasing access to this treatment. So let's talk a little bit about that. Quick note here at the bottom of the screen, you'll notice an advocacy piece. Related to all of this is a lot of discussion about changes to the Affordable Care Act, possible replace and repeal with something else. A lot of changes that are being suggested for Medicaid specifically, whether that looks like a block grant, whether states would even have expansion opportunity, either to continue the expansion that they've already done or to expand to a low-income population. We know that that is key to access to medication-assisted treatment and other substance use recovery services. So if you can help advocate by calling your members of Congress and working with your state's governor to really recognize the importance of Medicaid in all of this, that is a correlated issue that's very helpful here. Just want to also highlight some council resources that we've put together on opioid disorders. In particular, for the clinicians on the call, we have clinical guidelines that were updated a couple of years ago. These are still relevant. Please make sure that you're aware of these and sharing these in your community, as well as a couple of policy briefs, the other links to the other webinars that we've done, but in particular the current policy brief that we did in the fall, looking at the federal law and regulation changes that some of our speakers are going to talk to today. So I don't want to be taking up any more time. Let's talk more about who will be talking. We've got a great lineup today. Brian Altman from SAMHSA is going to talk more in depth about what SAMHSA and the administration are doing, some of the policy changes that are going to increase both prescriber rights and access. We've got a great team from Baltimore Healthcare for the Homeless, Dr. Nilesh Kalyanaraman and Laura Garcia, our nurse practitioner there. And then from Portland, Oregon, a Central City Concern, we've got a good team there, Dr. Seserstik and Lydia Bartholomew. And of course I'll be moderating some of the questions. You will see in the bottom of your screen a place where you can type questions. If you've got questions as our conversation is moving forward, please feel free to type them into there. We've got about 10 minutes at the end of our presentation that we've planned to try to come back and answer questions that weren't addressed during our presentation. So with that, I will turn it over to Brian to talk a little bit more about the federal policy changes and what SAMHSA has on tap for us. So Brian, why don't you take it away?
Thanks, Barbara, and thanks for having me on this webinar, and thanks for everyone joining. Obviously, everybody knows that we're in the midst of an opioid epidemic, and our former secretary had a 3-point plan to address the opioid epidemic, and one of the points was increasing access to medication-assisted treatment. And so we've taken a number of steps to do that, both through the regulatory process as well as through funding opportunities. So I want to start with our largest sort of first regulatory action that we took. So the Secretary had the authority to increase the highest number of patients that practitioner could treat to 275. And so at the time that rulemaking was going through, the term practitioner meant physician, as we'll get to that, now NPs and PAs can prescribe, but the 275 limit still only pertains to physicians. So right now, a physician can treat up to 275 patients through one of two pathways. They can do so if they've already at the 100 patient limit, which existed prior to this rulemaking, and they either have additional credentialing and or work in a qualified practice setting. And so generally what that means is for the additional credentialing, there's a series of organizations that either certify or provide other types of credentials to show that you've had additional expertise in addiction treatment. And so there's the specific organizations that have been laid out in statute prior to that are the same ones that you can hold either certification or board certification from to obtain the additional credentialing. Secondarily, you could work in a qualified practice setting, and there are 5 elements to that, and they range from having access to health information technology if available, registering with your PDMP where operational, accepting third-party payments for any services, and having options for how to provide case management services, as well as how to provide emergency coverage when your office is closed. So those are the sort of 2 general pathways you could move from 100 patient limit to 275 patient limit if you were a physician that already had a waiver. The other option is through what we call the emergency situation exception, and that is sort of as it exactly details. You have to have a sort of public health emergency in your area and describe it in sufficient detail to SAMHSA to seek that emergency waiver, and that waiver would last no longer than 6 months. And it also would require that you describe an explicit and feasible plan to meet the public health needs of the area that you have indicated have been impacted. And so I know we've had hundreds of people apply for the 100 to 275 waiver through the 2 pathways, and we've also had approximately about 30 people apply for the emergency exception to date. With the additional patient limit, it also comes with additional responsibilities and reporting requirements, and those reporting requirements sort of reflect the additional responsibilities in terms of things like having a diversion control plan and describing a little bit about what that entails, and the fact that you are checking a PDMP if you have one available to you. So as I said just a second ago, the other way we really expanded access to opioid treatment is through allowing NPs and PAs to prescribe buprenorphine in the first place. So this was not something we could do on our own here at SAMHSA. We didn't have the authority, but the Comprehensive Addiction and Recovery Act, or CARA, which passed in July of 2016, did allow NPs and PAs who meet certain criteria to be able to prescribe buprenorphine as well. And so like the physicians, the NP or the PA must be a practitioner who's licensed under the state law to prescribe Schedule 3, 4, or 5 medications for the treatment of pain. So if there's a particular state where NPs or PAs are not allowed to prescribe those schedules as medications, then they would not be able to get a waiver. They also need to take 24 hours of training in order to be able to obtain a waiver, and that training is available, will be available through SAMHSA or one of the organizations listed on the screen. There's a bunch of acronyms. We can get people those names if you'd like. And so once they've completed the 24 hours of training and they prove that they are a qualifying practitioner, starting hopefully next month, they'll be able to fill out the waiver form to apply for a waiver as an NP or PA. And that would allow them to treat up to 30 patients, which is the initial threshold for doctors who have, are obtaining a waiver at the same time as well. So along with the increased access to treatment, we want to make sure that people have also access to guidelines and resources to ensure their practice is along with the guidelines that we have established through various means. And so we have a lot of guidelines and resources available on our website. We have a specific web link, as you can see here, that provides all the information about medication-assisted treatment and buprenorphine in particular. And so you can go to that webpage and learn more about these rules and regulations and options and find the waiver forms, et cetera. And we also then have very particularized trainings for people who want to prescribe medication-assisted treatment or conduct it, as well as people who want to better their practice for prescribing opioids prior to help prevent people from getting a substance use disorder or opioid use disorder. So we have PSSO, as we call it, the Physician's Clinical Support System for Opioids, which is the training and mentoring program designed to help people understand the best prescribing methods of opioids, so to ensure that their patients don't misuse or abuse the medication. The PCSS-MAT is the training and mentoring project developed for those physicians and now nurse practitioners and PAs who want to prescribe medication-assisted treatment, whether it's buprenorphine, methadone, or naltrexone, but want to learn more because it's not usually part of their daily practice on how to do that best. And they provide trainings, webinars, mentorships, et cetera. We also have what we call TIPS, or treatment improvement protocols. We have TIP 43, which relates to MAT specifically, and it obviously goes more in depth and is a hard copy than any particular webinar or quick course. We also have information on how to best use extended release injectable naltrexone for treatment of opioid use disorder. And we also have a TIP 54, which equips clinicians with practical guidance and tools for treating chronic pain in adults. So that would sort of be the corollary to the PSSO. TIP 43 would be the corollary to PSS-MAT. And then the clinical use on naltrexone is a brief guide because that is sort of the newer of the products on the market in terms of the three, methadone, buprenorphine, and naltrexone. And so as that came on the market more, we wanted to make sure people knew and understood how to utilize that. We also have, wanted to make sure that a lot of tips and other clinical guidelines are hard copy. We realize that people are on the go and utilizing different methodologies now. So we've also created an app, MATX. It's a mobile app to support medication-assisted treatment of opioid use disorders. So physicians, NPs, PAs now can download that app and get some of the same resources, et cetera, that you could get in other things. So it includes things like our treatment locator at SAMHSA, critical helplines, buprenorphine prescribing guide, other clinical support tools such as treatment guidelines, ICD-10 coding, et cetera. So you can download that app and get all that information at your fingertips without having to go back and read through a whole tip or practice guide. So a couple other things that we have going on at SAMHSA. So that's all sort of in the clinical space and the regulatory space. We wanted to make sure you knew about other HHS activities to expand medication-assisted treatment. So last year, the Food and Drug Administration, FDA, approved Probufine, which is the injectable buprenorphine, so it lasts 6 months, I believe. You get one injection. It's like an implant, essentially, and the implant stays in for 6 months. And so they obviously are just getting people onto that medication, so we don't have a lot of outcomes or know all of the pros and cons of that medication at this point in that form. But it's certainly a way that for people who don't want to go to an opioid treatment program, OTP every day for their methadone, or go to their physician's office for a prescription of buprenorphine or a shot for naltrexone, so this allows you to sort of get the medication ongoing for a 6-month period. SAMHSA has a series of grant programs, as I said, that we've put out for increasing access to MAT. So in fiscal years 2015 and 2016, we had a program called MAT, Prescription Drug and Opioid Addiction Grants, and those grants went to states. And so we had 2 cohorts of those. I think they were about 12 and 13 each. We have about 25 states that have received those grants. But then with the passage of the 21st Century Cures Act, that included a new program that is a $1 billion program over 2 years. And so in December, shortly after that law was passed, we released another funding opportunity announcement, which allows for every state and DC to have access to funding for MAT and recovery and prevention services. And so that FOA is currently open, and each state is applying for that with the due date of February 17th. And that is a formula-based grant, so the funding opportunity announcement indicates exactly how much money each state would get, assuming they turn in an application of sufficient quality. Last year, the Health Resources and Services Administration, HRSA, also put out a $94 million grant program to increase access to MAT in community health centers. And ARC, the Agency for Health Research and Quality, also put out a few grants for MAT in rural primary care. And then writ large, as we would say, one way we know that MAT is being increased in access to is through mental health and substance use parity. The parity law was enacted in 2008. It was applied to the marketplaces through the Affordable Care Act, as well as certain Medicaid and CHIP plans. And so in all those areas, by requiring parity, it increases access to MAT as well. So that is my portion of the presentation. I think we're taking questions at the end.
Excellent. Before we move on to Nilesh and Laura in Baltimore, Brian, just so that we can be clear for folks, and I anticipate this major question that we'll get at the end, when do you anticipate that nurse practitioners and physician's assistants will be able to write prescriptions and all of this will be live for them on the ground?
So it sort of will probably depend. So it depends on a couple of things. One, we believe we are very close to being able to post the form that an NPRPA would have to fill out. So that was one piece of the puzzle that had to get approved by the Office of Management and Budget. Secondarily, there's this 24 hours of training that they have to take. What we have said is that 24 hours is split between the 8 hours that the physicians have had to take, and anybody can take, any NPRPA can take that 8-hour training now as the first part of their training. And then the 24-hour, on the 16-hour piece, our PCSS MAT program has developed a training. We're waiting to get continuing education approval. So when people take it, they get CE credit. And then each of the individual associations named in the statute that can provide the training, I believe, are also working on developing their 16 hours of training and are close to being able to make that available as well. So it somewhat, so all the training and the forms should be available, I would say, definitely hopefully by the end of February. And then the practitioner dependent on how quickly they take the training and fill out the form.
Excellent, thank you. Okay, so why don't we get a little familiar with the projects that will be talking with us today, so I'll turn it over to our team in Baltimore.
Thank you, Barbara. So this is Nilesh and Laura here in Baltimore at Healthcare for the Homeless. and just wanted to give you a quick snapshot of our program and what we're doing. So we're a federally qualified health center focusing just on the homeless population, and we have three clinics, one in downtown Baltimore, one in West Baltimore, and one in Baltimore County, where we serve over 10,000 people a year. Last year we had 110,000 visits. We provide a full range of services: medical, behavioral health, including mental health and substance abuse, dental, nursing, case management, outreach, and supportive housing. And our treatment philosophy is really person-centered, trauma-informed, and we'll get to harm reduction in a minute, and we work through multidisciplinary care teams. So we're really trying to address all of the needs that people have. We know that people have multiple needs the second they hit our door, right? They have homelessness, they have some health condition that brought them in, and then they have other health conditions that aren't even concerning them at the moment, but that have not really been addressed for a long time. And so we're trying to do all this in a harm reduction setting. And I think one of the biggest challenges for the field is how to really apply harm reduction to all aspects of not just care, but particularly what we're talking about today, the treatment of substance use disorders, and how to kind of take us out of our more rigid frameworks of how we treat substance use disorders and put some more flexibility into that. And so what we're talking about today, having nurse practitioners and PAs be able to engage that, is really a step forward in that paradigm. In terms of the number of people we serve, we have about 60 people currently in an initiating MAT treatment, and we'll talk more about that in a minute. And then in the past year, we've served approximately 500 people with predominantly Suboxone. So in terms of entering care, we adhere to the no wrong door philosophy. So pretty much whenever somebody wants care, our goal is to try to figure out how to get that to them today. And so if somebody presents to their medical provider, we'll see them, and then we'll get them hooked up with somebody in the addictions team to do an assessment and an intake and make sure, assess really what's the right level of service for them. Oftentimes that's us in the ambulatory care setting, but sometimes people need more intensive care initially, whether that's detox services or a residential program, and so we'll calibrate that based on what they need. The other piece of that is that maybe they're seeing some other service, maybe they're seeing the dentist or the case manager or whatever, and being co-located, having co-located services at all of our sites and multidisciplinary care teams as well, means that we can make those connections quickly and easily instead of referring them across town, and then who knows what happens to them after that. We also have on-site pharmacies at each of our locations so that people can get their medications. And we do naloxone training as well, and that's actually part of the intake process, is getting people trained in naloxone. So, you've managed to find the wrong door, but we got you through the right door anyway. What does it look like? So for folks, what we do is we have a structured addictions treatment program, an intensive outpatient program, and prior to doing that, we do an initial intake where we have a treatment agreement where we go over the guidelines for our program. We also review their prescription through a prescription drug monitoring program, their prior prescriptions to see if they're getting any opioids or they were on treatment before. And we do find that a lot of people were on treatment, whether with Suboxone or methadone in the past. In fact, I would say probably upwards of 95% of people have been on buprenorphine in the past, with a sizable proportion getting them on the street, not prescribed, but from other people. And we can verify that through their urines. And we do client-managed induction, which means that we give people a prescription and instructions on how to titrate their doses if they haven't already been on a stable dose. And we find that's really effective. Some of the older paradigms were really keyed in on having people come in every day for dose adjustments. And that typically tends to be necessary for people who were on smaller amounts of opioids and this is their first time on maintenance treatment. But as I mentioned earlier, the vast majority of people have already been on it and they know how to manage it on their own. We do have daily group meetings as part of the treatment program. With weekly individual counselor sessions so that we can customize their treatment plans for them, and then weekly, once a week MAC groups so we can assess their buprenorphine dose, make any adjustments as needed, and we find that as time goes on, sometimes people do need higher doses. Oftentimes that'll happen either in the first few weeks or about 6 to 8 weeks later. And we do weekly urine screens as well. If people are doing well in the structured treatment program, they go into our maintenance program where they transition to either a primary care provider or a psychiatrist. Typically what this meant is that when people engage with their primary care provider, if it was a physician, that was easy to coordinate. If it was a nurse practitioner, then that nurse practitioner would continue to do all the primary care, but would have to spend an inordinate amount of time hunting for prescriptions, which really just creates a lot of wasted effort. And frankly, the nurse practitioners would tell us what they needed us to write for. So it's not as if we were providing some amazing service that they didn't already have on their own. So being able to consolidate care with the nurse practitioners is going to be really key for just making our patients' lives easier and our staff's lives easier as well. And then continuing individual therapy or counseling as needed and engaging in continued group care. So in summary, our care is really geared once again around multidisciplinary care, and we calibrate the intensity of the services to what people need at that time. So I know we're going to take questions at the end, so I'll turn it over to you, Barbara.
Thanks. And at this time, why don't we just get a quick agency snapshot and how Central City Concern organizes its program. So I'll turn it over to Lydia and Brianna.
Great. Thank you, Barbara. And we're really excited to be here today and back to talk about MAT for opioid use disorder and some of the ways that we're going to be able to expand access and also improve the quality of care. So just a brief snapshot of our current programs here at Central City Concern. So Old Town Clinic is a healthcare for the homeless F2HC. We're a primary care medical home, and we're housed within a larger social services agency, which is Central City Concern. Our goal really is to provide low-barrier, patient-centered, and holistic care. Our overall MAT philosophy is that MAT is most effective when it's offered as a part of a comprehensive and individualized treatment program. And so this does include medication, of course, but we really emphasize the importance of counseling and also community support to really support recovery in our folks. And our substance use disorder treatment is fully integrated within primary care, so that's really our goal is we're primary care first, but we offer the A&D treatment within primary care. So we have warm handoffs to addictions counselors. So you're seeing the patient that day, you can hand it off to a A&D counselor to get them started and thinking about some treatment options. We have a full range of treatment groups here on site, including dual diagnosis and pain management, and also sort of an introductory course on understanding addiction. And for patients who are actively engaged in our program, we meet on a weekly basis as a team with provider champions to discuss patients and monitor their progress and come up with treatment plans and whatnot. So overall, our clinic serves about 5,000 patients. In the last year, over 175 have been treated with buprenorphine in our program, and currently we have about 50 active patients. So our program has really grown quite a bit since we started in 2013. We started with one counselor and a couple prescribers, and now we're up to 3 counselors, a supervisor of the team, an administrative assistant, and 8 prescribers. So we've really grown quite a bit. Some important features of our program, we have a lot of similarities with the program in Baltimore, but specifically we're also trying to address stigma in general around addiction and changing language and culture around addiction as well. And so some of the monitoring practices that Nilesh was talking about include pill counts and urine drug screens and bubble packing of medications and our treatment agreements, and we require that they come to groups at least twice a week. As you know, homelessness comes along with addiction in our patients, and so we have been able to secure some beds in our supportive housing. Our on-site pharmacy has been really helpful with collaborating on taking care of patients. We have lots of different dispensing options, bubble packing meds. We are able to do daily dispense for a few patients, and we also do weekly dispense of their prescriptions. It's also been sort of an emphasis for us to improve our overall provider education around addiction. So we have quite a few addiction-trained physicians and nurse practitioners already. We've been doing lots of education sessions for our providers on different substance use disorder treatments. We also offer some other wraparound services, such as specialty mental health, case management, benefits and employment, and housing. And then also we have naloxone training and prescribing. And then I'll hand it back to Barbara.
Okay. So at this point, just quick kind of overview on what these two projects look like in Baltimore and Portland. But let's get into the meat of some discussion here. And we'll start off with program impact. So Brian had talked about the CARA law in the Congress as well as the administration changes. What do we think that expanding prescriber rights and all of these changes, what do they really mean for our programs at HCH or other homeless healthcare providers? And I'll start with Portland. Your thoughts on where you're likely to see most impact?
Great. Yeah, so I can speak to that a little bit. So the first change is lifting the caps and increasing the total number of patients you're able to prescribe to. And for our program, we don't feel as though this is going to have a huge impact for us. You know, as I mentioned, we're pretty highly saturated already with addiction-trained docs, and we have 8 prescribers at this point. So currently our supply is pretty robust and it's enough to meet the demand. But the climate elsewhere is not that way. You know, there's a paucity of addictions-trained providers across the nation, especially in places that may have more of a need in rural areas, for example. So I think this will have a big impact in places where maybe they only have one or prescriber who is currently trained, or maybe they have none. So I think for our program, not a huge impact, but potentially larger impacts elsewhere. Expanding provider rights, I think, is going to be most helpful for our program, and we'll kind of talk about some of the reasons in the next slide, I believe. But many of our PAs and NPs are really excited about this because they're in an environment right now where we're doing really high-quality addictions treatment. They want to be part of that. They want to be able to take ownership of their patients and treat them for their addiction as well as their other medical issues. And I also think this is going to be huge for access across the nation in places where right now there's just poor penetration of buprenorphine prescribing.
Yes, I think the other thing that is going to be useful for us at Central City Concern, it may not apply specifically to the primary care clinic, but we're going to have much greater financial sustainability outside of the primary care clinic, ensuring that other addiction treatment programs throughout our system have consistency in their prescribing, and we'll have more prescribers in those locations because, frankly, NPs and PAs are cheaper, which is just going to allow more access to care.
And then Baltimore, what's your thoughts, or what would you add to that discussion?
So this is Laura Garcia. I think there's, for the Baltimore program, we have short-term and then long-term things that are going to affect the program. So in short-term, as Nilesh already said, we do have NPs who are managing these patients in primary care once they are already stable. And then tracking down an MD provider to sign a script. So immediately this is going to improve quality of care for patients. They're not going to have to wait as long. We can actually be writing our own scripts and getting them out the door quickly, which we all know patients really do not like waiting around. Also going to instantaneously make training for providers who are managing buprenorphine consistent. Whether you have a nurse practitioner who had training in school or had some type of alternate training that maybe the MDs had done, there's no consistency to that. So it will immediately make the training consistent. And then you have the long-term effects, because similarly to the Portland program, we're not going to be able to increase our actual MAT group capacity very quickly. We do need to have behavioral health supportive capacity for that, and we are saturated with that. But there is still definitely need. We have more and more patients who are coming who want to start on buprenorphine. So in the longer term, as we can also increase our behavioral health capacity, then we maybe will be able to increase the MAT group capacity.
And the one thing I'll add is that buprenorphine treatment is oftentimes a hook for people to engage in care for their substance use disorder, and so being able to provide that more easily is just another way to engage people, and that's part of why we try to engage people on the day they appear and write a prescription that day. Is if we don't, we say come back tomorrow, not sure if they will, right? And so this depressurizes our system and allows us to handle that capacity with greater ease.
One question I'd have is a greater financial sustainability using other provider types. What's your thoughts about how that correlates there with NPs and PAs and financial sustainability?
Well, aside from paying less, it also means that it also makes it easier in terms of staffing. A lot of programs tend to have to hire somebody specifically to do that particular piece. I think that we are, a little pat on the back, that in the healthcare for the homeless community, we're fairly progressive in this and hiring people who are interested in providing comprehensive care. But for a lot of practices, they don't have this capacity. And so they have to hire part-time psychiatrists or part-time physicians who do this. That adds just the logistics and cost. And so being able to expand this to nurse practitioners who are able to do this will decrease some of that complexity of delivering care.
So what I'm hearing you say is that particularly for smaller clinics or health centers or projects in the country who are nurse practitioner led, this actually can help not only expand access, but it is a cheaper way of staffing that where physicians aren't possible.
Yeah, cheaper and simpler, I think, probably is just as important. We find that in the nurse practitioner community, there's far quicker adoption of new services, new techniques, which is really what we're talking about here.
Okay. Let's move on then. I know a number of you have talked about quality of care and access to care in some of your responses on program impact. So can we expand a little bit upon that, and maybe we can start again with Portland about where you see quality of care and access to care being changed through these policy changes?
Sure. So I think as far as quality goes, it's going to allow for our nurse practitioners and PAs who are already the primary care provider for a patient to be the one providing that addiction care and MAT treatment. So the continuity of care is going to be there, and there's going to be that intimacy in the relationship because you're seeing your provider, and there's not going to be additional work that needs to happen to build that rapport and that relationship. So it's going to improve the quality there. And I also think that overall it's going to improve addiction treatment in general because more of our providers, more of our NPs and PAs are going to be trained in addiction care, and that's sort of going to permeate through the rest of our providers as well. As far as access goes, I mentioned that we are pretty saturated with prescribers at this point, but it's still, we still are sort of running into a point where the patient needs to be induced or there's a follow-up that's needed, there may or may not be an availability of a ND appointment. And so, just increasing the pool from which you can schedule patients for inductions and allow for quicker access and easier access, I think is going to be really important.
And just to build on that and also to reflect on what Nilesh said earlier, I really think that one of the things that's going to shift here is sort of less clunky coordination is how I would talk about it. So right now we often have patients who have a psychiatric prescriber, a primary care provider, and then they also have a buprenorphine prescriber. And so this will really allow us to sort of cut down on that clunky coordination, which I think ultimately allows for better care that's safer care.
And Baltimore, would you add to any of that, or do you have a different view on quality and access here?
I think we definitely agree with that, and I think just to build off that last piece, the safety in care, having to coordinate care between 3 different providers when you are writing multiple prescriptions, making sure that we are maintaining patient safety can potentially be very difficult. We don't have that issue at HCH because most of our patients are receiving all the services in-house, but for patients who are receiving services in 3 different locations, that's a very different discussion.
Anything more we want to add on quality and access before we move on? Okay. And I know quality of care is obviously a goal that we're all shooting for. I think one of the things that you both talked a lot about was that care coordination and simplifying the number of people that are involved in a patient's care so that can be more streamlined. And I think as we start identifying best practices at SAMHSA, these are the kinds of things that are really going to emerge as making this easier. So I just reiterating some of the themes that you've spoken to. Let's talk a bit about how to support these changes. And so thinking about how that looks inside our organizations, or what does that look like in our broader healthcare community on how are we able to most strongly leverage these changes on increased caps and in particular increased prescribing rights to be able to get where we need to go on meeting demand. So curious your thoughts, and we'll start with Baltimore. How is your organization supporting these or planning these changes to be implemented?
So in Baltimore, we are, Laura actually just started the training for this, and we're looking at how we can make space for all of our nurse practitioners to take that training in the next few months, so that really by the middle of the year, we have all of our nurse practitioners who've gotten their X license and are able to prescribe this. In addition, we're looking at how we're structuring our behavioral health services, particularly looking at our addiction services and how we can make them more flexible, working within a structure but also individualizing care better so that we can accommodate people where they are. I think one of the biggest challenges with current addictions treatment is that oftentimes it can be a little bit rigid, and if people don't do well within those systems, what leeway do we have to address that? So it's not just the MAT piece, but also the framework within which the MAT is residing. And then in whichever state you're in, advocating with insurers to drop prior authorization requirements. I know that a number of states have just done that recently. Here in Maryland, we don't require prior authorizations, at least through Medicaid, certainly not through Medicare for buprenorphine. So that makes it a lot easier. And frankly, prior authorizations are the bane of every provider's existence. So if a state is really serious about that, that's a way to tell, frankly, whether they're putting their money where their mouth is.
Portland, what would you add to that?
Yeah, so I think from our organization, it starts with really a high degree of commitment from the leadership in our organization for MAT, and it's not just at our clinic, but throughout our other services throughout the agency. And it's really sort of permeating things like other outpatient treatment and supportive housing and all those things. And so at the clinic, we've had some pretty good leadership support for CME and trainings for NPs and PAs. So basically, as soon as this law was passed, we started spreading the word about it and encouraging people to go ahead and get that 8-hour training and start doing more addictions training with the anticipation that, you know, they'd be able to prescribe soon. And we're hearing that within the next month is going to be a possibility. And even prior to that, we were encouraging our NPs to get an addiction certification, and so which is possible for our NPs. And a fair number of them have already done that. So we sort of just increased the level of education here on addiction treatment. And I also want to echo Melicia's comment about working with your payers to drop the PA requirements. And so we were able to do that successfully working with our CCOs here in Oregon. It has made a huge difference just from the administrative burden and patient quality. You know, you're not having lapses in prescriptions because of prior authorizations that haven't gone through, and you're not delaying care because of, you know, the need to have a prior authorization. So I think that's huge. And then I'll pass it off to Lydia. Comments?
I'm not sure I have a whole lot to add, except that as an NP, I felt incredibly supported immediately after CARA was passed to get trained. So I was trained last August in the 8-hour course, and I've already started the ASAM 16-hour additional course. And the larger organization has paid for all of my education and been very supportive in that realm.
Excellent. And in particular, really great to see organizations paying for your training. So that's also very helpful. Why don't we talk a little bit more about the ongoing challenges in making that work for treating this population, or just making it work in general. Why don't we start with Lydia and Brianna in Portland. Your thoughts about just what you see as ongoing barriers, or just the challenges in making this work.
Well, I think so one major barrier that we're working to combat that is definitely still there is the stigma around MAT, and that's not just in the provider community, but it's within sort of addiction treatment in general. So the idea that, you know, if you're using MAT, then you may not be truly in recovery. I think that's a stigma that we're combating on a regular basis. I think just the fact that we are requiring additional training to prescribe this medication can be a barrier. And I think on the one hand, yes, it does improve the quality of addiction training and sort of puts everyone on the same page and standards of care for prescribing buprenorphine. But it's also important to recognize that we don't have to do any of this training for other medications that we prescribe. You know, for example, I can prescribe oxycodone without an additional training. And so maybe I should have more training for that. And also just there's still, you know, a discrepancy between MDs who only have to take 8 hours of training and NPs and PAs who now have to do 24 hours to get this. So just recognizing that while it isn't important that we're expanding prescriber rights, there are still barriers to expanding this. Also just the fact that there are patient limits at all. You know, we know that we have an opioid crisis, an epidemic happening right now. Those patients are not evenly distributed amongst all the providers, so it's hard to really come up with like the ideal number of people we should be prescribing to. We sort of talked about the prior authorization issues, and that's just very inconsistent state to state. Medicare, different Part D plans, there's a lot of different rules, and it can cause issues with quality of care, as I mentioned, with people, you know, delaying their care or having lapses in their buprenorphine prescriptions. I think the last thing I'll mention is just the DEA audit process and all the sort of record-keeping rules that go along with buprenorphine. I think it can be daunting for some folks, and it can be really intimidating. We actually just had a DEA audit for one of our providers, and we had a bunch of things in place. We had a great policy. We provided everything. Everything went really well, but it was still, kind of unnerving and pretty disruptive to clinical care that day. A provider was pulled out of clinic for an hour or two, and so I think that sort of maybe clinics who don't have a lot of administrative compliance or legal support may be intimidated by that, and they may choose not to prescribe because of that, which I think would be a shame.
So I just have one quick thing to add to that, which is I think that the initial communication about expanded prescriber rights and sort of how NPs and PAs would have access to these was pretty poor initially. So the disorganization at a national level, or the confusion is really a better word, I think, for the NP colleagues that I have on how this process would go, I think it's been confusing. So it's a 24-hour class, which is a heavy burden, but really what's been, I think, a bigger burden for NPs thus far is trying to figure out, okay, do these 8 hours count? How do I make up the other 16? And there's been a lot of sort of miscommunication and even some kind of odd rumors floating around. So I think webinars like this are going to be helpful as we move forward.
And Baltimore, Nilesh, and Laura, anything to add to that about the barriers you see, or the challenges, rather?
Well, I think one of the bigger challenges that is elucidated in the differing state laws with prescriber rights is that this discussion is very pertinent for providers, so NPs and PAs in some states and less so in others. Because if you can't prescribe certain levels of controlled substances, you won't be able to actively prescribe this either. And there still are quite a significant number of states where this is not going to expand access to anyone. I happen to live in Maryland, where luckily enough it will. But the other component of that, which is also state-based, is that insurance coverage, and the fact that living in Maryland we have expanded Medicaid, which has been covering this, which has allowed us to write this. In states that did not participate in expanded Medicaid or have different types of insurance coverages, they may not have the same type of access. So this is still very differing access across state lines.
Yeah, I agree with what we've been talking about. I think the DEA audits and the record keeping are probably the thing that weigh on providers' minds the most. Some upfront effort to do training and get your X license is a one-time thing, but even though the audits tend to be low-key, in primary care we don't get audited for anything in this way except for this one particular medication, and it's a barrier that doesn't really serve any useful policy role in the sense that this is a treatment or a crisis that we have, and looking at dropping that requirement, I think would go a long way towards assuaging providers' minds that this is actually something that's not going to bring them greater scrutiny, but something that is necessary. And I think the other piece that we have to talk about today is that the general political atmosphere, when we were planning this talk, wasn't quite this way. But talks of repealing or tearing down pieces of the ACA, block granting Medicaid, doing something to Medicaid, these create a lot of opportunities to disrupt care for the people that we're serving and that others are serving as well. And anything that's going to reduce access to care, anything that's going to reduce the coverages that are provided, are going to necessarily affect this as well. And so, we should just note that as we're talking about this.
Thank you. I think all very good points. We're in the last few minutes. I think we hit on a lot of, we covered a lot of ground across a lot of different issues. Want to open this up to questions. If you haven't, if you have a question and haven't yet plugged it into the Q&A box, please do. We have had a couple of questions roll in, and so I'll start with a question that came in for Brian. Will the NP and PAs be able to increase to 100 patients after 1 year like MDs can?
Yes. So there's nothing in the statute that changes that 3,100 time frame and patient limit for NPs that is different from the MDs. So they would be able to apply for the waiver to increase to 100 after a year.
Great. And then do you happen to know, I know you work for SAMHSA, so you may not have all the HRSA grant pieces, but do you know the $94 million for the MATs and health centers, is that currently awarded or is that currently out for application?
No, that was awarded last March. So there was a HHS press release March 11th of last year, and there's a link in there to the FQHCs that received that funding.
Got it. So a couple of questions that came in. For patients on Buprenorphine, sorry, is that correct? One of the providers correct me, Buprenorphine, does that count toward the numbers of current Buprenorphine patients? So
yes.
Is that, maybe that's a question for Brian, okay?
Yes, so we certainly looked at this issue as we were going through the rulemaking process for the 275, and what we would determined is that there was certainly nothing at the time based on the recent approval and few number of patients who had actually been provided that to give us guidance on how to deal with it other than as we do with everybody else on a buprenorphine formulation. And so we had indicated in the final rule that it's certainly something we would continue to look at as more people are on that formulation of the medication, and that we would, look at that in the future in terms of if the pros outweigh the cons of either, creating a higher cap or counting those patients differently towards the cap or not having a cap at all. We would explore that that question later, but because of the limited amount of time that had been approved and the few patients have been on it, we couldn't sort of get to any other conclusion right then.
Got it. And then, Brian, I know that you may have covered this earlier, but just wanted to be clear. Where can NPs and PAs receive addiction certification? It might have been on one of your slides. Do you want us to backtrack to that, or did you want to show that again?
Sure. So we used a bunch of acronyms on the slide. I think it's slide 6. But essentially, so they're named in the statute itself. So essentially, SAMHSA can provide the training through our PCSS match, and then you can, NPs and PAs can take the training through any one of the other organizations that are named in the statute. And they're on, I believe, slide 6. So those are all the acronyms, but if people need, you can Google the acronym or you can look in the statute, or I can spell it all out later.
And I'd like to add to that. This is Lydia again. I'd like to add to that because I think what the question is referring to is actually about addiction medicine certification for NPs as opposed to just the 24-hour data waiver. So if you'll notice at the end of my name, I've got the CARN AP, which stands for Certified Addictions RN Advanced Practice, and that's available through INSTA. And you don't need that to get the data waiver, but it's been one of the things that that Central City Concern has promoted for NPs.
Got it. Helpful. Thank you. We have a last question that came in. Since we're FQHCs, how are health centers billing the MAT encounter? Baltimore, did you want to start with how you bill for MATs?
Sure. There's a couple of ways, but right now there's a couple of ways to do it, and it may vary by state. But because it's part of primary care, it's billed as part of a primary care visit. That's really what is the simplest and the most reasonable, as we're talking about this being a issue that's dealt with in primary care. We also have the state's mental health administrative services organization allows us to bill for substance abuse services, but our behavioral health providers are billing for that, and they can bill the groups through that. When we meet with folks with the groups, we're actually pulling them out and doing individual treatment sessions with them, and so they're structured the same way as an individual visit. We haven't quite tackled how to do it in the group setting. It's doing the prescribing piece in the group setting itself. And there are some ways to do that. For Maryland, it would require being an outpatient mental health program, which we are not, because we are already a primary care program.
Got it. And Portland, do you do it differently or similarly?
We are the same. Yes.
Okay. Okay. Again, we've covered a lot of ground. We're at our hour. Really appreciate everyone coming. I just want to remind everyone that this recording will be available and posted to our website. And, whoops, sorry, just trying to get some technical issues here. And then want to also make sure that just thanking our speakers for coming today. Really appreciate Brianna and Lydia in Portland, and Lesh and Laura in Baltimore, and Brian from SAMHSA. Appreciate everybody coming to attend this webinar today, sponsored again by the Healthcare for the Homeless Council, largely through our cooperative agreement with HRSA at HHS. So please look for additional training opportunities in the future, and I know when this closes out, you'll be getting an evaluation. Please fill it out. This helps us understand how we can provide better trainings for you. And again, just want to thank everyone for coming today. And at this point, we will close out the webinar. Thanks so much.